have the pleasure of introducing my good colleague and friend, Dr. Karen Maroda. And as many of you that might be watching this conversation we have today will know that she is a senior analyst and psychologist who has been quite influential in forging many of the movements that have occurred in the relational psychoanalytic tradition today. She, in many ways, came on the scene with a landmark book called The Power of Countertransference. And she's also made a big splash with a book by Guilford on psychodynamic techniques. But today we have her latest, I suppose, new masterpiece that we're here to discuss, and it's called The Analyst's Vulnerability. Her new book that just came out, and she's been gracious enough to meet with me today to talk about what she's done in that project. So maybe we might start, Karen, with you in your own words, just kind of giving the audience, a general overview of the focus and the scope of this new book of yours.
Okay, John. Thanks for having me. Always happy to speak with my good friend, Jon Mills. This book, it took a while for me to organize it and try to decide what to do, because I had these two lines of thought. I was thinking how we have still to this day insufficiently addressed our own personal involvement. In spite of the tremendous progress we've made with the two-person movement overall, I still found, particularly in my practice where I treat and supervise so many therapists, I started noticing all of these dynamics that we all shared that really were not sufficiently portrayed in the literature. And so the more therapists I treated over the years, and in spite of any differences in age, gender, culture, I kept noticing, these recurring patterns and primarily of, as I say in the book, of, on the positive side, unusual sensitivity and empathy and perhaps vigilance to others' feelings, but also companion feelings that were not so positive, of being easily ashamed of motivations for doing treatment, ashamed of any guilt, or ashamed and guilty about any anger they felt toward their patients, and reluctance to be more assertive, and a preference for being passive, which then I started connecting in reading the literature on enactment and seeing the popularity of enactment growing and growing. I started making the connection between those two phenomena, and realizing that our theories weren't just like a general reflection of our worldview, but were specifically tied to personality traits that we share. And so my mission became to outline, and that's why the first part of the book is The Analyst as a Person, was to discuss all of those traits and our early experiences that determine not only our vocational choice, but also how we practice, how we think of the dyad, how we're inclined to act toward our patients in general, and then also how that's reflected in our theoretical preferences. And again, specifically with enactment, I feel that enactment promotes passivity and unknowing. And I think that in many ways that lets us off the hook for what goes on in treatment. And I have always advocated for us being more assertive and more active in treatment. So I always say I write a new book every 10 years because these things kind of percolate over time, as both my clinical observations and then my thoughts about theory. And out of those two worlds came this new book.
Very good. I think you and I, in many ways, have had similar careers. I've had a lot of engagement with supervising therapists, And but I've had less of treating them than I've had supervising them. And I mean, it's always kind of been unspoken that we all know that we've gone into this profession because of some type of crap that we went through in childhood. I mean, it's just not really been, so open to talk about until recent, maybe the last couple decades. But I'm wondering, based upon your experience, what kind of common characteristics would you kind of say that you've observed in this capacity?
Well, they're the things that I outlined in the book. Primarily, something I noted many years ago was that I myself, I don't think have, and I'm not sure exactly why, but so I wouldn't say that all therapists have this, but in general, I think there's an exaggerated fear of doing harm that's to our patients. And I note that too when I'm supervising therapists, or if, when I'm on the road, doing workshops or giving lectures, and meet with people in the audience, and they'll present something to me and they'll ask me about a patient or be formally presenting it to me. And I say, well, have you thought about these feelings that you've been sitting on about the patient? Or have you thought about setting this limit with the patient? So it could be that they've been sitting on anger. It could be that the patient isn't paying the fee. It could be that the patient's being abusive. And I started noticing that when I ask, have you thought about confronting this more directly? The answer I would get all too often was, oh, I'm afraid that I would hurt the patient if I did that. And I said, all right, well, sometimes we hurt each other's feelings. What if that happens? Oh, well, this patient might be suicidal. This patient could possibly be suicidal. And I would say, well, has the patient ever attempted suicide? No, but they're very depressed and, they could. And so to me, that seemed like quite a stretch. Or the patient would leave. We have lots of fears of abandonment. Mm-hmm. So it seemed that to me, over and over again, the analyst's fear of hurting the patient, driving the patient away, even driving the patient to suicide, ruled their interventions rather than being able to think in a freer way about what the patient needed. So I would say the things that we share that get in the way of doing our best in treatment are that excessive fear of doing harm, tendency toward passivity. And I think that comes from because we were necessarily passive as children. We had no power or authority. So we had to make do with a low power position and work to soothe and comfort rather than confront. So I think that passivity is a natural continuation of our positions in childhood. That's not sufficiently examined either in the general or specifically in treatment. And I think part of the reason that this continues generation after generation is because we all share this and we don't internally question it. So we pass it, it's intergenerationally, nurtured and perpetuated because it's not ego dystonic for us.
Yeah, even within psychoanalytic theory, as you critique, like the whole notion, your experience of what your training was like, very much mirrored mine. It's like the transference can be so powerful that you become even more passive, perhaps, than you would be by just accepting what you're being told or expected to do, or what role you should be playing as a student in training. Mm-hmm. One of the things that I was trying to grapple with is, and I don't believe you make a broad sweep this way, but there's some implication that there are certain universals that all therapists tend to have, and I'm wondering if you've encountered any outliers, like in therapists, where instead of being passive, instead of being sensitive to others, instead of being empathically inclined, that they have opposite characteristics, and they tend to be, more active, more, authoritarian, or more patriarchal, or whatever kind of traits that might fall in there. And I'm just curious if you've encountered that.
Yeah, yes, certainly. I do think there is a small percentage of therapists who behave in that way. And I think I made a very brief mention of it in the book. And that I wasn't going to concern myself with them because I didn't think most people who would be reading the book would identify with them. But I think, yes, I think just as in all helping professions, including clergy, there's a certain percentage of people who are drawn to those essential power positions, those positions of influence, from a place that is not, generous or bad, that's self-serving or narcissistically motivated. So I think a worst case scenario, some of those people are sociopaths, and best case scenario, maybe more malignant narcissists. And I think, of course, we have those people in our profession, as all professions do, but I don't think that that's the norm. I think those are the outliers.
Okay. Sometimes when I was reading your book, I was struck by the thought that our vocation chooses us rather than we choose it. And I wonder, but I'm also mindful that I don't like simple, causal reductions.
Sure.
But I wonder if you think there's any validity to the thought that this is kind of sort of, unconsciously determined or motivated.
I do think that it is, but I don't think, I agree with you. It's not that simple. I think you could say that about any person going into any profession. So, I think at some point we do make conscious choices. Certainly, those of us who've spent the time getting PhDs and MDs and, advanced analytic training, regardless of degree. I think that kind of commitment has to be born in adulthood out of a more personal and deliberate choice. I think that that it's not unconsciously determined in only a negative sense. I think it's that we're motivated both, and I say this in the book, both consciously and unconsciously to make these choices because of the inherent rewards. Now, granted, we didn't choose that position that gave us the rewards initially, but we were chosen for the role because of certain talents. And I think people choose vocations based on talents that they have.
Yeah.
So I don't want to give the appearance of reducing our vocational choice to some pathological formation. I think that we were innately empathic, sensitive, interested in others. And those are some of the positive aspects of our choice. And that, as my colleague Brian Smothers said, that I quoted in the book, is that we have taken pride and come to need the sense of specialness that also goes with it. So there's the ongoing, transformative possibilities, the living in the world of intimate emotion, the being rewarded for our ability to navigate that world. Those are all positive things rather than it's simply a pathological choice.
Sure. One of the things that you nicely address is questioning the notion of the ideality of a therapist. And it's symptomatic of our training too. I think that how our professors, how our superiors, our instructors have presented kind of this ideal either position in the analytic dyad or the treatment frame, but things that you could never really live up to, and that it almost seems like a transcendental illusion that you nicely say is that we can't transcend our nature. We more or less have to embrace it and wade through the journey into psychic pain with the patient and ourselves.
Right.
It's-
And don't you find too, I mean, I find with supervisees, and I know, as you said earlier, you do a lot of supervision. Don't you find that early career therapists of all ilk feel tremendously and unnecessarily inadequate because they know they can't be that ideal person?
Yeah.
And they feel like imposters.
Yes, it happens all the time. And I guess part of more of your critique is when the analyst acts like the one who knows, as if this is the way you should be in the consulting room, and we're all just kind of struggling in there together. And I also liked how you talked about your personal training experiences and how you wish you were told up front that beware, because you're gonna be dragged through the weeds here, and it's gonna upset your own internal psyche, and just get used to it right now. Yeah.
Right. And again, that's why so many therapists feel like they're imposters, because young therapists will say to me, not only are they not perfect, but because they are so overstimulated by their patients, intense internal experiences, they also feel that they are psychologically not fit often. And they're afraid to tell anyone how discombobulating taking in all that emotion is, especially early in your career, or can be. And I think that's a shame too. That's not happening to them because they're not healthy enough to be therapists for the most part. It's happening to them because that's what happens. Yeah. And it takes years to be able to regulate your responses and be more at peace and not be so discombobulated. But that capacity for being discombobulated never goes away. It's always there.
Mm-hmm. Yeah. Well put. I mean, even like it, as one goes through one's career, it's not like you've mastered this. It's not like you don't struggle with your own normative human emotions and conflicts.
Right.
Perhaps we get better at that. I was trying to read your book both in a receptive way, because I identify with you and your approach. At the same time, what am I critical of? And not much.
Well, that's good. Not really. I'm always up for a debate, John. So I'm happy to hear your critique in either direction.
No, it was just more refreshing. It's more like, I'm not going to sit here and pretend now at my age, even though I've done this for whatever 25 some years, 30 years, gosh, even more than that. You've got it all figured out. It's just that I know that I'm not the same person that I was when I was in training, and life experience, forming a professional identity, going through adulthood. I mean, you get to a different place later in your career as a therapist. I think a turning point for me, and I think this is something that you address at great length, and that is on the level of responsibility that we have for the other. Like, to what degree are we inscripted into having to continually be the caregiver for the patient's emotional life, or that we have this radical responsibility for their own distress. And I remember saying to myself, I have no control over other people's lives, and I have really no responsibility for their life. And when I said that to myself, it really gave me breathing room.
Yeah. Well, it relieves you of that guilt-based approach. You didn't cause their pain, ergo, you are not responsible for their pain. But not to be confused with, you're not interested in doing what you can professionally to help them manage their pain and you have a better life, assuming that's what they want to do.
Exactly. Yeah. Well, maybe you can tell us more about your thoughts on that, because I was thinking about the difference between, like, I think it's Robert Grossman's the unobtrusive analytic posture.
Yes.
And then the other side was the radical Levinasian ethics of responsibility for the other that Donna Orange promulgates. Can you give us your thoughts on those two extremes?
Well, I don't know that I would. Can you tell me a little bit more about what you think is extreme about Grossmark? I don't really find his work that extreme, but maybe could you elaborate on that?
Oh, I guess what I meant was that from my reading or remembering about his approach is that he just doesn't want to intrude or obstruct anything that the patient wants to go through or experience or discuss.
I see. Okay. Yes. Right.
Which
yeah, no. To me, I mean, although I think they're more philosophical differences, maybe perhaps than practical differences. I'm not sure because Donna Orange talks mostly philosophically about her approach. And so does, I mean, they give clinical examples, but I mean, I think Grossmark thinks that he can be, again, to me, it's a perfect example of passivity. I think Grossmark endorses a very passive response.
Yeah.
That that you're there, you're present, you're internally processing, but you are not really, you don't have the objective of emotionally engaging or attempting to influence it. That it's a denial of our need to influence and even our patient's desire to be influenced and to not be influenced by us. That ambivalence. And I think that Donna Orange is endorsing a sense, again, it's more of an internal state, but an internal state of, Levinas's radical responsibility that I really should, as much as possible, as much as I can humanly possibly do it without damaging myself. This is my take on Orange. I should devote myself to you and helping you with your pain. And to me, that's just too extreme and not humanly possible. Mm-hmm. And I also think too, that it's a recreation of our childhood experience of having to make that kind of sacrifice. Mm-hmm. Mm-hmm. And that it promotes a continuation of us attempting to be excessively self-sacrificing, which inevitably leads to, falling short of that, feeling inadequate, and resenting it. As I say in the book, no one wants to be responsible for another person. We didn't want to be responsible for our depressed mothers or damaged siblings. Yeah. We didn't. We were assigned that task. And I think to keep reassigning it is not helpful. And I think to simply withdraw from it also is not helpful. That middle ground that I keep searching for and trying to create in my own work, including my day-to-day clinical work, is that balance of being caring enough, wanting to influence, being involved, trying to emotionally engage without being authoritarian or feeling responsible for the outcome. Mm-hmm. Mm-hmm. And also not sacrificing myself or denying my own humanity.
Nice. Well, yes, Levinas has been widely criticized, for imposing an ethics that is just not humanly possible.
Right.
And I guess it doesn't surprise us that Donna Orange, who was a nun, might adopt that humanitarian self-sacrifice. But your point about the unobtrusive stance is also made me think about, even though I agree with you, there's a passivity to the whole thing. And you almost alluded that it almost sounds like a kind of classical technique as well. I'm just going to listen. I'm going to be a receptacle. I'm not going to get too emotionally attached, but maybe you do. I'm not sure. I guess that depends. But the mere fact that, that the free associative method is one in which we're supposed to listen with, evenly suspended attention, not jump in and tell people how to live their lives and things like this. But I'm wondering if I'm convoluted in when I'm taking this, but I wondered if you do have a section on gender, a difference in therapists, and given that you treat and supervise so many therapists, can you say more about what you've noticed in terms of, in today's age, even talking about gender can be loaded.
Yes. Yes, I know.
We don't know how one identifies, right? So.
Right. And most of what I write, because I'm a product of my generation, I have difficulty. Like a couple of my supervisees refer to their patients as they, and it's just a standard pronoun they use now, regardless of what the person's identification is. So like if it's a female patient, if it's a male patient, they refer to that person as they. And as a former English teacher, I find that extremely challenging. I cannot I just really struggle with referring to an individual in the plural. It's just, so that's hard for me. All the pronoun, I understand the reasoning for it, the request for it, but I have to, admittedly, I struggle with that. And since most therapists do, the vast majority identify as male or female, I pretty much just stayed in within those classical gender classifications because, it goes beyond my scope to discuss it any other way.
Sure.
So like I said, I'm a product of my generation, but I think that certainly, and Levinson has talked a lot about this, and I quoted him, that there has been this tremendous change on the basis of gender in terms of our population of therapists, right? The majority of analysts in particular used to be MDs, used to be male, and were mostly Jewish. And now, that's its own, subculture. And it was known for its being somewhat authoritarian, arrogant, certainly not all, again, but, and rule bound. And I think that's part of the medical, education, especially from decades ago. And now most therapists, most analysts are women and come from many more different, varying cultural backgrounds. And that influence, and women do score higher on tests of empathy. Women are much more concerned about empathy. Women are much more likely to be engaged, to be helpful to their mothers, and in the household in general, and to be nurturing to others. And so I think that has definitely changed our persona, and that the two-person movement combined with that shift from MDs to PhDs and MSWs, and from male to female, has made an enormous difference in our approach. And I say in the book, both positively and negatively. I think that emphasis on self-sacrifice is greater, and guilt and the idea that you should give way or be passive is more classically feminine. And that also the greater capacity for empathy and for allowing for pain is also more classically feminine. We are the caregivers of the world.
Mm-hmm. Yeah, I mean, it's hard to really, challenge that. I mean, obviously people quibble and they get into these, the nuances of identifications and things like this. But I think it's a fair generalization based upon kind of a norm. But get it, and you made me think about this as you're talking. And I don't know if there's a correlation, but I know that you both and I have been very, critical to say, let's say, challenging of excessive self-disclosure.
Correct.
Do you think, based if there are gender differences that are operative in therapists, does that tend to correlate with one gender being more self-disclosing than another?
On the face of it, I would have said yes to that question until recently. But as I have worked more with young male therapists, I have discovered they often they self-disclose in a slightly less personal way, but that they are also tending toward excessive self-disclosure. And I've been told it was a result of their training programs.
Mm-hmm.
That they're encouraged to be more active interpersonally with their patients.
I see.
Without having any real principles or guidelines to follow.
Yeah.
And like, for example, like if they're attacked by a patient, they tend to get a little too defensive and try and explain their process and why they said what they did, when they really should have just been quiet and let the patient speak.
Mm-hmm.
They feel guilty, they feel responsible for the patient being upset, and they rush in to defend themselves.
Yeah, that's certainly not only common, but something I'm guilty of.
Well, we all do it. We
Yeah.
all do it. But I mean, it's human nature to want to defend when you're criticized.
This move toward self-disclosure, sometimes self-revelation, is potentially distressing to see, but at the same time, quite liberating that people are talking about their personal conflicts in open public political space. But at the same time, an uneasiness or an ambivalence is kind of left as some affective aftermath when I read these things, because on one hand, I'm saying, wow, that takes a lot of guts. On the other hand, it's like, oh, a little too exhibitionistic for me.
Yeah.
And you nicely put in your book that even if we can admit things and talk about our childhood in general ways, no one has the right to know the details. And for a number of reasons, respect for their dignity. Other people are going to read about them, perhaps patients or supervisees, and there's a number of good points you make. And I know that you have guidelines about self-disclosure, at least, around countertransference, around how do you deal with emotions. And it's not an easy topic, right? It's not clear cut. So I guess what I'm fumbling around with is what would there be a line between, I don't know, too much confessional that you would say you need to stop?
Well, quite frankly, John, I do not believe in confessional disclosures in treatment. I really don't.
Okay.
And in everything I've written, I have warned against giving out too much personal information, and that the heart of a therapeutic self-disclosure is an affective one. That it's about emotional engagement, and that very often what our patients didn't get, again, isn't that we would be better people than their parents, that we would love them more than their parents, and that we would disclose more to them than their parents. That's not anything I subscribe to. My point is what we can do that perhaps the parents often did not do is be emotionally responsive and in an authentic way and give emotional feedback to what the patient is saying and what the patient is feeling to help them define themselves, to recognize their own emotions, to manage those emotions, as Crystal says so eloquently. That all pathology, we used to call them emotional, disturbances, because it's all about emotion, regardless of the diagnosis. And that one of our chief therapeutic tasks is to help our patients name, feel, and express and manage their emotions. And they need a lot of feedback, and I refer to that as completing the cycle of affective communication. So listening, being receptive, being able to give honest feedback to our patients about our emotional responses to them, to me, is the heart of therapeutic self-disclosure, not personal information.
I've been at conferences where one in particular strikes me as bizarre, but where people disclose being sexually molested as children. And in one situation, the whole room is in tears. And in another situation, someone brought a patient of theirs and is discussing the patient in front of all the professionals in the audience. And another time, I remember somebody was in a wheelchair dying of MS and is talking about his impending death and bringing that into the session with all his patients. And so I don't know, I'm kind of left with, why would someone feel the need to do that in professional public space?
Well, that's an interesting question, John, and I'm sure there are many answers to it. But what comes into my mind when you say that is that they do that for the same reason that they may disclose too much on a regular basis to patients, and it's because in little outbursts, and I think it's because one of the negative consequences for us and for our patients is that we feel that we are not known, and again, it's human nature to want to be known. And over time, as we have these long-term relationships in the analytic, world with our patients, we want them to know us, but we're very restricted in that. And if we follow the old, guidelines, they don't really know us. But to me, the way to have our patients know us and the way that we know them that's most meaningful is their emotional reactions and our emotional reactions. We don't have to resort to all this personal information. But I think that so often we feel that we have stuffed down so much in our vocational choice, that we spend so much time behind the glass, that especially later in life and when there are crises and where we feel tremendously vulnerable, often later in our careers, there's like this last push to be known.
That's good. It makes a lot of sense. The need for recognition and mirroring in that way. But boy, I'm thinking if they're doing that there, they must be doing it in the session.
Yes, at that point they are. I would feel certain of that, yes.
And like all the supervisees I've had over the years that come from trauma backgrounds and their own abuse, and it's as if they were clueless what they were getting into when they now are having to encounter people who have been equally, if not more, traumatized. And so it echoes back to your early caveat about, you kind of wish people would be upfront about these things, that you should be in your own treatment. There's a lot of people, and I even heard some therapists who say they wouldn't even consider their own individual therapy.
Yes.
It's like, well, these are the worst kind of people that are being turned loose on the public. At least that's my opinion. But I'm segueing into another thing that I'd like to see how do you get around this, because you said that you should not start treatment with anyone that you're not interested in.
Mhm.
And then you elsewhere, I think, say that if there's no emotional connection between you and the patient, that the whole treatment's both hopeless and unethical.
Yes, I do say that.
Yeah. Now those are big boundaries there.
They are.
So by definition, though, we do know that there are patients that we take on, and we might not like them, and we might even grow to dislike them during the treatment. And what do we do there?
Well, quite frankly, again, in both my own clinical experience and in supervising other therapists, I have not seen a good case of that being transcended during the treatment and having a really positive outcome. I've never seen it. I supervise therapists who say, I feel really bad. Now I feel even more guilty because I've been treating this person. I thought I should treat them. They wanted to be in treatment with me. And now 2, 3, 4 years later, they're no better than they were when they came in the door, and I can't stand them anymore.
Mm-hmm. Mm-hmm. Mm-hmm.
So I've never had somebody, and if there's anyone who feels differently and wants to, communicate that to me, I'd be happy to hear it. But I have never had somebody say they really didn't like the patient to begin with, took them on because out of guilt or because they had an empty hour, and tried to make the best of it. I have never heard them say that they were able to transcend that and ultimately engage with the patient. You see cases where patients have great difficulty engaging, and yet you're still interested in them, and you want to work with them, and there's some way you're connecting. And then, because there are patients, of course, who have great difficulty getting to their feelings. And that's a different story. If you are interested in them, you feel a connection, and you think you can help them expand that and become more expressive and accepting of their emotions, then there's a good chance that will happen. But if you don't like them and you can't connect at all, I think the prognosis for that treatment is very poor.
Yeah, it raises a dilemma because, for instance, by definition, people really shouldn't probably be treating character disorders. I mean, these are folks that we don't particularly like, or forensic populations. So,
although you would assume that, that's not necessarily true, because I have seen therapists who had parents who were character disordered, and they found something. People aren't all good or all bad. They had to find what was good about that person. And they do become often engaged with people who are personality disorders because they know that person and they try to heal that person, and they repeat that in their practices. And they tend to minimize the character pathology and maximize any feeling or vulnerability that they can find in that person.
Mm-hmm.
So it really depends on your early experience and your perspective. Like I said, I think I said in the book that one person's pathological liar is another person's creative storyteller.
Mm-hmm. Well, it reminds me when you were talking about Mary Target's patient.
Mm-hmm. Yeah.
I mean, and I'm thinking the same as you. It's like, there's no way someone's going to trash my office. And I'm going to sit there and watch them. So it almost seemed surreal that someone would not react to someone trashing their room, or screaming and yelling at them and just sitting there and taking it. And
Well, and ostensibly not being really disturbed by it.
Yeah.
Even.
So she says.
So she says, right. But, you know, I thought it was very generous of her to discuss that case with me. And I think it's a fascinating case.
Well, I mean, you know, the reason why I brought that up is that, you know, it was not easy for me dealing with a great deal of character pathology, particularly in my early career where I was specializing in it and working with psychosis and as well. Very difficult population groups, and if anything, I just kind of had to, I think, to probably survive it, not get too emotionally attached. And then something happened. The relationship developed, and it moved beyond that. But at the same time, and you write about this, and most people don't. They don't talk about all the blunders, all the failures, all the people bolting from treatment. And I had a 20-year treatment happen to me with that too, that she abruptly stopped, didn't come back, didn't want to schedule, and you wonder what went wrong. But it does happen, and I guess I'd like to maybe tell us more about the analyst persona, because in many different literature groups, this comes out, like how does one present themselves as a professional? But there is a persona. I mean, it's not like I'm going to act like this to the patient who's in here in front of me, you know, in this manner that we are. It would be bizarre. I mean, I'm going, if I have to go to work, I have to go to work, and I'm there for a purpose, and I'm there for you who's sitting in this chair. But so
sure, because I think what you're talking about is what used to be discussed frequently in the literature as, you know, the work ego. You know, that we put on a certain hat when we walk into the consulting room, and we deliberately alter behaviors, you know, and generate other behaviors, and often bringing out the best in ourselves. we are often, I think, and that's another reward of the job, is that we are our best selves often with our patients. But then there's a whole other context of how do we define best self, and that's where we get into the aspects of persona. Is our best self our authentic yet controlled professional, you know, constantly evaluating self, or is our best self the excessively empathic, you know, more passive, receptive vessel for the patient, and, you know, willing to sacrifice and engage in things. By the way, I think too, is that notion of self-sacrifice leads to many, many boundary violations. And again, also, I think one of my supervisees was mentioning that the men, speaking of gender things too, men will call patients out on not paying their fee. They're, as a group, less likely to, I think, to extend sessions, you know, or do things that are excessively self-sacrificing. And for women, what gets embedded in that self-sacrificing persona is, not only am I going to feel your pain and make it my own, or do I think I should be able to do that, I'm going to run over on the session if you start crying, thereby leaving the next patient waiting in the waiting room while you give that patient their time, which creates all kinds of problems, of course.
Mhm.
So I'm going to start late, I'm going to end late, and most therapists will acknowledge that that's an ongoing problem for most of them, is not being punctual. And I think a lot of that is based on that self-sacrificing persona. So it becomes, is our persona that we are authentic, or is our persona that we are self-sacrificing and passive? I think that we need to work more on loosely defining a persona that we think is constructive and beneficial to most patients. That would include things, like I'm a big fan of Gabbard and Guthiel and all their work on boundaries. That includes starting and ending on time, avoiding excessive personal information.
Robert Langs.
Yes, yeah. I mean, and Lang's, he suffered so much criticism, especially because the two-person movement was taking hold right after his heyday. And so he got kind of trashed in many respects and doesn't get the credit he deserves because he was always talking about the frame. Yeah, and that we need to stay within the frame. And I think the frame, as Gabbard says, has to be permeable to some extent, but you can't toss the frame away.
No.
And in fact, we need to work more toward defining a flexible frame that is constructive and therapeutic.
I think that gets into the notion of how do we have a professional persona, even though the word persona is a little bristly. I mean, it almost, it immediately assumes you put a mask on, you're fake.
Yeah.
A veneer, a facade, and there's the real person back there. How do you navigate having a professional identity and presence for the patient, engagement, but at the same time, not sacrificing your authentic way of being? And you talk about this compassionate authenticity. I thought maybe you could reflect on that a bit for people watching.
Well, I think you're right, John, that that's not easily achieved or even easily defined, because, and I do talk about in the book that some sacrifice is required. And people have different levels of comfort with sacrifice and different capacities for sacrifice. So again, what might be comfortable for you and not take away from you might be uncomfortable for me. And I think that that's part of the match with patient and analyst is, do we match on that level? Do you need a therapist to sacrifice to a certain point that I am not really willing to do or not comfortable with?
Mm-hmm. Yeah.
So you have two levels of looking at it. What does the person naturally do and is comfortable with? And then the more sticky area, what's healthy? What's therapeutic? And then ideally you want to blend those two and then match up with patients on those variables, on the personal comfort variables, so that you can have a free-flowing, successful treatment. But I would not deny that, just sitting, listening to someone for 45 or 50 minutes while they talk about how helpless or hopeless they feel or how much they want to die involves sacrifice. Most people are not capable of doing that. And that's why I always tell therapists when they say, I think I should be doing something more, or I interrupted my patient when he or she was talking about their pain because I just felt so overwhelmed and I felt like I had to do something. And I always say, what we do when we're successful, which is to listen for as long as the patient needs us to, and only come in as needed, is a very, very difficult task that almost no one can do. And so don't underrate that activity. Don't underrate the capacity for, and also ask yourself, did you come in because you thought the patient was overwhelmed, or did you come in because you were overwhelmed?
Yeah, you mentioned earlier about this is the pragmatics of being in private practice. Is I have a free hour. I need to keep my income up. I don't, people talk to me, colleagues talk to me all the time about their anxieties around having too many cases, not enough. They're always worrying when it's going to dry up, and excessive anxieties around that might fuel them taking on too much.
Sure.
And you talk about how theory is personal, and so I guess on one hand, there's no question that anything that we engage in has got to be a personal enterprise. It's a subjective enterprise, so you can't experience the world without subjectivity, but it doesn't mean that everything's reducible to just the self. So I maybe you can give us your take on what you mean by how theory is personal.
Well, I think theory is personal in the sense that I was trying to think of it in terms of my own, decisions. And one of the things I say in the book is that I always hated it, not only that I had to be passive as a child in view of things that I thought should change, in my family of origin, but had no power to change. So I rejected passivity at an early age rather than falling into it, and for whatever reason, and that I hated how passive my mother was. And so I very quickly and easily identified passivity as, I think, an unhelpful yet common trait in therapists. So that's just a tiny example of something that incorporates into my view of what good treatment is, or what my theoretical stance is versus the analyst position, because I think that we are way too passive and not active or assertive enough. And that comes from my own personal life. And I think our overall theory, there's all the stuff about Kohut and his narcissistic vulnerability and him creating self-psychology and all of that. And Stolrow and Atwood talked about that extensively, in the 70s, that all of our theories are necessarily personal, just like all writing is necessarily autobiographical, right? It comes from it can't be born from anything other than our personal experience of the world. And what I say is that the more kind of the healthier and more broader based our experience is, and healthier we are, the more likely we are to create a theory that applies to more people and is generally accepted. And the more idiosyncratic we are, like Lacan, and is the more marginalized, or the smaller following there will be. So I think that some people have broader experiences that allow them to create more general theories, and other people have more idiosyncratic or unusual experiences that create more marginalized theories. And so that it's a combination of our unique personal experiences, our unique genetic makeup, and then the common universal or quasi-universal experiences of having been chosen to be the family caregiver.
Okay. What do you think's disingenuous today in contemporary psychoanalysis?
In theory or practice or both?
Yeah, or just anything in particular that comes to mind.
Well, I think that there are a lot of things I think are disingenuous, but I think that they're not to be confused with like ill intention. Do you know what I mean? I think people with the best intentions infantilize their patients too much. The whole idea of holding and accepting and reflecting and doing that for years on end, and being reluctant to confront patients especially with their bad behavior, or to limit abusive behavior toward the therapist, or like you said, setting basic boundaries, like you have to pay my fee. We need to, I didn't get a payment from you, and we need to talk about that. Mm-hmm. Mm-hmm. And this whole idea that patients are are so vulnerable, and that it's even in their best interest to have that infantile aspect of them indulged. I don't think it's healthy. And I think that it's too common of a thought that, and this translates into treatment, clinical decisions, that we really need, that it's kind of what I call the poor baby approach, that we need to see that our patients are victims, they're victims of sexual abuse, they're victims of everything. They're poor victims who need our loving, better, not just good enough, but better parenting to rescue them and save them from their despair. And I just don't think that's reality-based or possible or productive.
In terms of that, I think, let me try to rephrase the question. I was thinking about, is there something that you're critical about in today's landscape, but maybe sensitive or difficult to broach, or it might appear too taboo or politically incorrect?
Well, I think my views that I stated extensively in the book on how mirror neurons have been grossly misapplied in analytic treatment, and that most people can't even tell you what a mirror neuron is, and yet they will write and talk about how the basis for empathy in their treatments is based on mirror neuron theory and research, and it's not. And that's why I combine mirror research and empathy together, because most of what we believe and apply is completely untrue or unproven. But why do we choose it? Because it fits with our idealized view of this magical unconscious to unconscious connection between us and the patient.
Mm-hmm.
And that's why I talk about the limits of empathy too. And many people, from Mitchell to neuroscientists, have talked about how if you could achieve this perfect empathy, and again, maybe some people try to do it by saying, yes, I was sexually molested too. If they want to totally immerse themselves in the patient's world, the misguided idea is that would lead to this unbelievable magical healing response. I experienced just what you experienced. I'm feeling just what you are feeling.
Yeah.
And yet all the research on empathy says that's most likely to lead to an unhealthy merger and inevitably to a lack of empathy because of excessive identification and inability to assess what the patient really needs in that moment, because you've become lost in a merger with them.
Well put. Yeah, I sometimes question why, sorry.
Some water there?
I sometimes question, why are people writing about it? And why are they disclosing these things about what they're saying to the patient? And it almost seems like it's inevitably a crisis moment or a moment of confusion, or not even an impasse, but they're flustered and they need to say.
Would you say it's an enactment?
Well, that seems to be the new lingo, right? For countertransference.
Great.
And maybe that's a good place for us to try to end on, because that paper that you wrote for psychoanalytic psychology, that one of the chapters in your book is one of the better pieces that I remember reading from you in recent history, and trying to really tackle this question head on. I mean, isn't everything an enactment, though, when you boil down to everything's personal, everything's about a subjective engagement with the world? How can we not enact? Versus the countertransference kind of traditional definition of an unconscious negative emotional reaction to what's going on in the moment. Can you just ferret out the differences?
Yeah, I think if you take the broadest possible definition of enactment, and that we're enacting and we're stimulating each other and determining each other's responses and even unconsciously influencing each other with our emotional reactions, I think then you can say everything's an enactment. But I don't think we benefit. One of the points I make, as you know, in the paper, is I don't think we benefit from those huge umbrellas that we create sometimes, just like with empathy and other terms in psychoanalysis. I think if once you broaden it to cover everything, it becomes meaningless. It means nothing. An enactment used to refer to a more discrete event, and you can still use it this way, and I do, without denying that ongoing influence. And you can say an enactment is an event, and was always defined as such, is something happens out of the blue. It's a surprise. And suddenly the therapist or the analyst is behaving in a way that is probably not very good. There's an outburst of emotion and often untoward behavior. Getting angry, yelling at a patient, being sarcastic or derogatory toward a patient, getting openly exaggeratedly out of control, with some feeling that induces guilt and shame and a retrenching on both parts. And something that has to be something that now has to be processed and deconstructed in itself. And that inevitably leads to a self-disclosure, because the therapist has to figure out, why did I do that?
Yeah.
And so those things happen with some regularity. So I prefer to stay with enactment as that discrete kind of surprise event that just comes spontaneously out, and the therapist feels out of control, and then now has to bring all that down and calm the waters with the patient, who typically has a strong reaction. And often there's even like an argument or a quarrel or a fight involved,
Sure.
But one of the points I make about that, though, is that those intense, what I call discrete enactments, although I do believe they're inevitable, happen far more often than they need to, because I think they're the result of therapist guilt about anger toward a patient, and that they sit on that anger. And I make the point of saying, if you read cases of enactment in the literature, 90% of the time, either the therapist doesn't say what they were feeling before, or more than often than not, they talk about feeling frustrated and angry with that patient, and then ultimately starting to disengage from that patient out of fear of being out of control. And what happens when you do that is that stimulation is still occurring constantly, and eventually there's this acting out by the therapist that we call enactment. And my point is that if we were to be more productively processing those negative feelings and trying to find a constructive way to express them and give feedback to the patient, we could avoid a lot of these tumultuous, even scary enactments that occur.
Well, very well put. I have for years recommended your psychodynamic techniques books to all my supervisees, and now I proudly will be recommending your new one.
Thank you very much, Jon.
It really, I think it's a great text for anyone getting into the profession. You're candid and you're honest, and you're vulnerable, but not too vulnerable. And
not too much self-disclosure, right? Some.
I think it's a good role model for particularly the next generation of therapists and analysts. So thank you very much, Karen, for meeting with me today.
It was great talking with you as always, Jon. Thank you.
Okay, well, take good care.